Welcome to Beyond the Stethoscope, the podcast specifically for general practitioners. Today, we are doing a significant deep dive into a topic that, well, it touches so many of your patients, and it's a constant challenge: chronic pain. We've compiled a really comprehensive chapter looking at, everything from definitions to management, all tailored for busy GPs and, importantly, for those preparing for fellowship exams. Our mission today: to really unpack this complex area, pull out the key insights, and hopefully equip you with a clearer understanding, a better way to approach chronic pain in your daily practice. And joining us is our expert, who's going to help us navigate all the nuances and translate the evidence into, practical takeaways. We'll be looking at defining chronic pain, the different types, that crucial shift towards non-pharmacological management, effective assessment techniques, and the role, or sometimes the limited role, of medications. We'll also touch on specific things to think about for children and the elderly, and the complexities of conditions like complex regional pain syndrome. So let's get started.
Great. And it really is a significant area for GPs, isn't it? I mean, just think about the numbers. In Australia, around 20% of your consultations will involve someone with chronic pain.
20%, that's huge. 1 in 5 patients.
Exactly. It's a massive part of the workload. And it's not trivial pain either. It significantly impacts about 1 in 5 Australians aged 45 and over. The financial burden is also, immense. Estimated at $144 billion in Australia back in 2020. That's around 10% of GDP.
Wow, those figures really hammer home the scale, don't they? And it's not just older patients we're talking about.
No, absolutely not. A really striking figure is that 68% of people living with chronic pain are actually of working age.
68%.
Yeah, and for over half of them, about 56%, it leads to significant functional restrictions.
So it directly impacts their ability to work, to live their lives fully. And I know the impact goes beyond the purely physical side of things.
Oh, definitely. There's a very high comorbidity with depression and anxiety. Around 45% of people with chronic pain also struggle with these. And tragically, the risk of suicide is also significantly higher, something like 2 to 3 times the rate in the general population.
That's a really sobering statistic. It underscores the profound effect this has on overall well-being.
It really does.
And there's been a definite push, a real shift in thinking recently, away from relying so heavily on long-term medications, particularly opioids.
Yes, a very important shift. Current best practice, the guidelines strongly emphasize non-pharmacological approaches first, empowering patients, active self-management, that's key. The dangers of long-term opioids are clearer now, too. Those Australian statistics from 2018 showed, I think, an average of 3 opioid-related deaths per day, mostly unintentional prescription overdoses.
3 a day. That really highlights the risks and why their role in chronic non-cancer pain is, often quite limited.
Exactly. It puts a lot of emphasis back on the doctor-patient relationship, doesn't it? The chapter calls it a yardstick of excellence in managing this.
A yardstick of excellence. I like that.
Yeah.
Okay, let's dive into the fundamentals then. How do we actually define pain? It sounds simple, but it isn't always.
No, it's not. The International Association for the Study of Pain, the IASP, defines it as, and this is worth knowing, an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage.
Sensory and emotional, that's key.
Absolutely. And a really crucial distinction for us as clinicians is between pain itself and nociception.
Okay, explain that difference.
Well, nociception is the neural process. It's the nervous system encoding potentially harmful stimuli. Think of it as the body's alarm signal detecting potential damage. Pain, though, is the subjective experience of that signal. It's personal, and it's heavily influenced not just by biology, but by psychological factors, social factors. It's unique to each person.
So even if we can't find, say, a clear structural reason on a scan that matches the patient's level of reported pain, we still have to respect their experience as real.
Precisely. Their report of pain is the gold standard, really. We have to respect that.
And having a shared language to talk about pain is obviously vital. The chapter has a glossary, which is useful. Maybe we could touch on some key terms GPs really need to know, like allodynia.
Yes, definitely. Allodynia is a really important one. It's basically pain caused by something that wouldn't normally hurt.
Like clothing touching the skin.
Exactly. That would be mechanical allodynia. Or maybe a cool breeze causing pain, that's temperature allodynia. A non-painful stimulus becomes painful.
Got it. And then anesthesia dolorosa. Sounds like a contradiction.
It does, doesn't it? It's pain in an area that's actually numb, lacks sensation. It's a complex neurological thing, often very difficult to treat.
Okay. Analgesia is straightforward absence of pain. Breakthrough pain, we hear that term a lot, especially for patients already on pain meds.
Yes. Breakthrough pain is that sudden flare-up of pain that happens even when someone's background pain is reasonably controlled with their regular medication. It often means we need to tweak the treatment plan.
Causalgia, the chapter notes, it's an older term for CRPS type 2.
That's right. Historically, causalgia referred to that intense burning pain after a specific nerve injury. It's now generally classified under complex regional pain syndrome type 2. You see that burning pain, extreme sensitivity, allodynia, hyperalgesia, and often those physical changes like skin color, temperature, swelling.
Okay. Central pain starting from a problem in the CNS itself. In central sensitization, this seems like a really core concept for chronic pain.
Absolutely pivotal. Central sensitization is basically an amplification of pain signals within the central nervous system, the brain and spinal cord. It's like the volume knob for pain gets turned way up.
So the system becomes hypersensitive.
Exactly. This can lead to pain spreading, pain from minor stimuli, and pain that just keeps going even after the initial injury seems to have healed. It's a key driver in many chronic conditions.
Dysesthesia, that's described as an unpleasant, abnormal sensation. What might patients say?
They might describe it as burning, prickling, shooting, tingling, sometimes even weird sensations like formication, feeling like insects crawling on the skin. That can be a type of dysesthesia.
Okay. Hyperesthesia is just increased sensitivity generally. And hyperalgesia is when something that should be painful feels much more painful than expected.
Spot on. Like firm finger pressure that would normally be just uncomfortable becomes intensely painful. That's hyperalgesia.
Then there's hyperpathia, which is a bit different again.
Yeah, hyperpathia is interesting. It's an increased, often explosive reaction to a stimulus, especially if it's repeated. But paradoxically, the threshold to trigger the pain might actually be higher initially.
So harder to set off, but a bigger reaction when it does.
Pretty much, yeah. And the pain often persists after the stimulus stops.
Okay. Hypoesthesia is decreased sensation, and hypoalgesia is reduced pain from a normally painful stimulus.
Correct. Incident pain is pain brought on by a specific activity like coughing, moving a certain way, weight bearing.
Things patients learn to avoid.
Often, yes. Neuralgia is pain following a specific nerve pathway, often sharp or shooting. Neuritis is inflammation of a nerve.
Neuropathic pain, we've touched on this pain from damage or disease in the nervous system itself, peripheral or central. Neuropathy is the general term for nerve dysfunction.
Whereas nociceptive pain is the normal pain response activation of pain receptors due to actual or potential tissue damage, like a cut or arthritis inflammation. The nervous system is working as intended, signaling harm.
And then we get to the third category, nociplastic pain. This feels like a newer concept for many of us.
It is relatively newer in terms of formal classification, but it's incredibly important for GPs. Nociplastic pain is pain arising from altered nociception. So, changes in pain processing, but without clear evidence of actual tissue damage activating nociceptors, and without evidence of a lesion or disease in the somatosensory system itself.
So it's not straightforward nociceptive or neuropathic.
Exactly. Central sensitization is thought to be a major underlying mechanism here. The pain processing itself is dysregulated. It's often a diagnosis made after excluding other causes, and the presentation can be quite variable, sometimes widespread, maybe non-anatomical. Think conditions like fibromyalgia, some types of chronic low back pain, or irritable bowel syndrome.
That's a really helpful distinction. Paresthesia is that pins and needles feeling. Phantom pain, pain in a missing limb, somatoform pain, physical pain linked more to psychological distress, and visceral pain from internal organs.
That cover the main terms. Getting comfortable with this language really helps in diagnosing and communicating about pain.
Absolutely. Now, building on that, let's recap those three main origins or mechanisms of pain.
Right. So first, nociceptive pain. Stimulation of normal pain receptors by injury or inflammation. The nervous system is intact, doing its job. Second, neuropathic pain. Caused by a lesion or disease affecting the nervous system itself, peripheral nerves, spinal cord, or brain, often described as burning, shooting, electric. And third, nociplastic pain. Altered pain processing, often involving central sensitization, without a clear nociceptive trigger or neuropathic lesion.
And critically, as you said, patients often have a mix of these going on, don't they? It's not always one neat category.
Absolutely. It's very common to see overlap. A patient with chronic low back pain might have nociceptive elements from degenerative changes, perhaps some neuropathic components if there's nerve root irritation, and almost certainly some nociplastic overlay due to central sensitization over time.
Which leads us nicely to the biopsychosocial model the chapter mentions. It's not just about the physical signals.
Exactly. That model is fundamental. It shows how the initial nociception interacts with the person's individual pain experience, shaped by their thoughts, feelings, beliefs, social context leading to suffering, and then the pain behaviors we actually observe as clinicians. We see the behavior, but we need to understand the whole picture driving it.
But that holistic view is essential.
Mm.
Okay, let's talk about categories based on time and context.
Right. We generally distinguish acute pain, recent, short duration, clear cause, usually resolves. Then there's cancer pain or palliative care pain requires a specific approach, often managed by specialist teams. And our main focus today, the bulk of what GPs manage in this area, is chronic non-cancer pain or CNCP.
CNCP.
Yeah.
And the big question is always, how does that initial acute pain, say, after an injury or surgery, sometimes morph into this persistent chronic state? Why does it happen in some people and not others?
That's the million-dollar question, isn't it? The transition is really complex, multifactorial, and honestly not fully understood. But we do know certain things increase the risk. Table 82.1 in the chapter lists key risk factors GPs should really be aware of.
Okay, what are some of the main ones we should have on our radar when seeing someone with acute pain?
Well, several factors seem to increase risk. Being female is one. Lifestyle factors like smoking, obesity, being sedentary definitely play a role. Socioeconomic factors, too, lower education, lower socioeconomic status seem to make people more vulnerable. And the circumstances around the injury matter, things like being on compensation, having a disability claim.
Right, so it's not just the biology of the injury itself.
Not at all. Other things include having multiple other health conditions, multimorbidity. There might be a genetic predisposition in some. A history of previous chronic pain is a big one, or already being on opioids before the acute event.
And psychological factors.
Hugely important. Things like catastrophizing, focusing on the worst possible outcome, pre-existing depression or anxiety, high levels of stress, poor coping skills. These all significantly increase the risk of pain becoming chronic.
That's quite a list. It really emphasizes how interconnected everything is. Does how we manage that initial acute pain in general practice actually make a difference in preventing chronicity?
The evidence suggests it can, yes. Early, appropriate acute pain management, which includes not just analgesia, but really good patient education about what to expect, reassurance, support, encouraging appropriate activity, all of that seems to help reduce the risk of transition. So our initial approach really matters.
That's a powerful message for primary care. Okay, let's hone in on CNCP itself. How do we define it clinically?
Generally, it's pain lasting more than 3 months, or sometimes defined as pain persisting for, say, 4 weeks beyond the expected healing time for a particular injury or illness. And it's crucial to grasp that CNCP isn't just acute pain that hasn't stopped. It can become a disease state in its own right, with different mechanisms driving it.
And we're back to central sensitization again.
Exactly. It's a key player in CNCP. The nervous system becomes persistently hyperexcitable. Receptors get upregulated because of the constant bombardment of pain signals, or sometimes even after the initial signals have stopped. This leads to those long-term changes in the CNS hyperalgesia, allodynia. The pain system is fundamentally altered.
So the pain experience becomes disconnected to some extent from the original peripheral input.
Precisely. And that's why the socio-psychobiomedical framework is so vital for understanding and managing CNCP. The patient's social world, their thoughts, emotions, level of physical conditioning, sleep, diet, they all feed into and are affected by the chronic pain experience.
So our assessment and management must reflect that breadth.
Absolutely. While we always need to properly investigate and manage any underlying pathology and watch for new problems, we also have to address these broader factors.
Yeah.
The chapter lists common causes. You'll see musculoskeletal issues, arthritis, migraine, endometriosis, and also conditions with a higher tendency to become chronic, like nerve injuries, shingles, inflammatory conditions like spondyloarthropathies.
All right, that gives us a solid foundation. Now let's get practical. How do we actually assess and measure pain effectively in the consulting room?
Good assessment is absolutely key. And we need to remember, as we said, pain is subjective. Patients with chronic pain are often frustrated, distressed, maybe even feel disbelieved, which can make assessment tricky.
A thorough history is still paramount, though. The chapter mentions PQRST and Socrates.
Yes, the classic history-taking skills are essential. PQRST, provoking palliative, quality, radiation severity, timing is a good framework. Socrates is perhaps even more comprehensive. Site, onset, offset, character, radiation, associated symptoms, timing, exacerbating relieving factors, severity. Using one of these systematically helps ensure you cover the key aspects of the patient's pain story.
And using body charts, can they be helpful?
Very helpful. Getting the patient to mark where they feel the pain, where it spreads to, can give diagnostic clues, especially for things like referred spinal pain or mapping out widespread pain like in fibromyalgia. It also provides a baseline to track changes over time. You can use full body charts or regional ones like for headache.
Okay. And even though pain is subjective, the chapter stresses trying to measure it repeatably. Why is that useful in chronic pain?
Well, while we can't measure the internal sensation, using standardized scales helps track changes. Is the pain intensity changing with treatment? Is function improving? It gives us objective markers over time. It also involves the patient in quantifying their experience, which can be empowering. The simplest are unidimensional scales, like the visual analog scale, the VAS, that 10-centimeter line from no pain to worst imaginable pain.
Right, the standard 0 to 10 scale,
Yeah.
essentially. And the FACES scale for kids or those with communication difficulties.
Exactly. The Wong-Baker FACES scale is great for that, but for chronic pain, we often need more than just intensity. Multidimensional scales give a richer picture.
How so? What do they measure?
They look at the impact of pain on function, mood, sleep, quality of life. Examples include the McGill Pain Questionnaire, the Pain Disability Index, the SF-36 Health Survey, or specific ones like the Oswestry Low Back Pain Questionnaire. They help understand how pain is affecting the person's whole life.
That makes sense, getting beyond just the number. Okay, let's shift to management. The chapter strongly advocates for a holistic approach.
Yes, this is critical. Effective CNCP management really requires tackling it from all angles: the biological, the psychological, and the social factors that contribute to the patient's pain behavior and experience. And right at the heart of this is patient education.
The chapter calls good explanation the most powerful therapy.
That's quite a statement. What are the key messages we need to get across?
We need to help patients understand that complex interplay, how their biology, their thoughts and feelings, and their social situation all interact. Table 82.2 lists factors that can increase pain, like fatigue, anger, depression, isolation, and factors that can decrease it, like positive mood, engagement, support, sleep, distraction. Explaining this connection is vital. And specifically explaining central sensitization, if that's relevant. How do you approach that?
It's about explaining, in simple terms, that the pain system itself, the brain and spinal cord, can become oversensitized. That the pain they feel is absolutely real, but it might not be directly related to ongoing tissue damage anymore. The alarm system is faulty. This can help reduce fear and shift focus to retraining the system.
Using analogies like a faulty car alarm can be helpful there.
Exactly. And setting realistic expectations is just as crucial, isn't it?
Absolutely. What does that look like?
It means being honest that a complete cure might not be realistic, but significant improvement in pain, function, and quality of life is possible. We need to manage expectations about medications, explaining that they often have a limited role, especially long-term, and emphasize that non-drug therapies and active self-management are usually the most successful strategies.
Which brings us to active self-management. That's where the patient takes charge.
Yes, empowering the patient is key. The best outcomes happen when patients actively participate in their care, supported by the GP and often a wider team. It's about learning strategies to improve function and coping despite the pain, which over time can often lead to less pain intensity too. Motivational interviewing techniques are great here, helping patients identify their goals.
So the goals aren't just get rid of the pain.
No, definitely not. Goals should be broader. Improving mood, increasing activity levels safely, reconnecting socially, improving sleep, better nutrition, maybe returning to work or study, focusing on function and quality of life.
The chapter lists a whole raft of non-pharmacological therapies in Table 82.3. It's quite comprehensive.
It is, and these are the first-line approaches. Under physical therapies, you've got general exercise, strengthening, aerobic, but it has to be graded, started gently. Hydrotherapy is often excellent. Physio, OT input is vital. Things like Tai Chi, yoga can be very beneficial too.
And the psychological therapies.
Key ones include acceptance and commitment therapy, ACT, cognitive behavioral therapy, CBT, mindfulness-based approaches like MBSR, relaxation techniques, biofeedback, counseling. Even simple distraction techniques can help.
Other things mentioned are activity pacing, acupuncture, and group programs.
Yes, activity pacing, learning to balance activity and rest is fundamental. Acupuncture helps some people, and group pain management programs can be incredibly powerful, offering education, skills training, and peer support.
It really underscores the need for a multidisciplinary approach often.
Definitely. Collaboration is often essential. The GP is the coordinator, but working with psychologists for mood and coping, physios and exercise physiologists for movement, OTs for function, nurses for education, pharmacists for medication advice, dietitians for nutrition. It takes a team.
And for really complex cases, there are the specialist multidisciplinary pain clinics.
Yes, referral there is worth considering for patients who aren't progressing, have high levels of distress, or major functional impairment. They bring together pain specialists, psychiatrists, and the full allied health team.
Okay, now let's talk about medications. The chapter positions them very clearly as second line.
That's the crucial message. They should only be considered alongside and in support of the non-pharmacological strategies. We use analgesics, pain relievers, and adjuvants, drugs with other primary uses that also help pain. And we need to be mindful that just prescribing pills can inadvertently encourage passivity.
Right. Let's start with the simple analgesics. Paracetamol.
Paracetamol. Mechanism not fully clear, likely central effects. Generally well-tolerated, liver metabolized, usual dose 0.51 g Q4 6-hour, max 4 g day. Need caution with liver or severe kidney issues. Available in modified release too. Generally safe but often limited efficacy in established CNCP.
Okay. Then NSAIDs, non-steroidals. Widely used, but lots of potential side effects.
Huge potential for side effects, especially with long-term use or in the elderly. They work by inhibiting COX enzymes, reducing prostaglandins, but this can lead to GI upset, ulcers, bleeding, kidney impairment, fluid retention, raised blood pressure, increased cardiovascular risk. Naproxen might have a slightly better CD profile, but the risks are still significant.
The chapter classifies them non-selective, COX2 selective preferential.
Yes, non-selective, like ibuprofen, naproxen, diclofenac. Selective COX2, like celecoxib. Preferential, like meloxicam. If using them, the advice is usually short-term, lowest effective dose. Celecoxib, ibuprofen, naproxen are common choices. Key point: review after a week. If no benefit, stop. And always try to deprescribe if possible. Aspirin is also an NSA with its own GI and bleeding risks.
And now opioids, the big one. As we said, the thinking is really shifted here for CNCP.
Massively. The evidence for long-term benefit in CNCP is really quite poor. Effectiveness seems similar between different opioids, and some patients actually feel better coming off them. Tapentadol has that extra mechanism, might help some neuropathic pain, but it's still an opioid. The harms are substantial: nausea, constipation, sedation, cognitive issues, falls risk, dependence, addiction, respiratory depression, overdose, death. Really significant downsides.
So the risk-benefit calculation for long-term use in CNCP rarely adds up favorably.
Exactly. Before even considering a trial, you need a proper risk assessment, clear goals focused on function, and ideally a written treatment agreement. If a trial is done, it should be short-term, low-dose, maybe buprenorphine patch, slow-release morphine, oxycodone, tapentadol, tramadol. Start low, go slow. Crucially, review regularly. If there's no clear objective improvement in function and quality of life, or if harms emerge, stop the opioid. Generally, use beyond 12 weeks needs specialist input.
Okay. Let's move to adjuvant medications, often used for neuropathic pain.
Yes, that's where the main evidence lies. Less evidence for nociplastic pain, though they are sometimes trialed. Target doses might be similar to their primary indications, but titration often needs to be much slower in CNCP, especially nociplastic, due to sensitivity. Antidepressants like TCAs and SNRIs can provide pain relief independent of mood effects. Sometimes two adjuvants might be used concurrently, but always with a regular review and attempts to deprescribe every 3-6 months.
What are the common ones in typical doses for pain?
For TCAs, amitriptyline or nortriptyline often started very low, maybe 512.5 milligrams at night, titrating slowly up towards maybe 75 milligrams, occasionally higher, but often lower doses work for pain. For SNRIs, duloxetine usually starts 30 milligrams daily up to 120 milligrams. Venlafaxine XR starts 37.575 milligrams up to 225 milligrams. Then the gabapentinoids. Gabapentin starts low, 100-300 milligrams noctate, titrating up. Max usually 3,600 milligrams daily. Max 300 milligrams CBD. Key point: both need dose adjustment in renal impairment and start very low in the elderly. Side effects like drowsiness, dizziness are common, and despite frequent use, their overall benefit can be modest, while concerns about misuse, dependence, and withdrawal are increasing.
What about other antiepileptics, or things like ketamine?
Other antiepileptics generally have limited evidence, except carbamazepine specifically for trigeminal neuralgia. Ketamine is really a specialist drug, used in specific settings, limited evidence for chronic use, potential for significant side effects. Clonidine is also specialist use. Cannabinoids, lots of interest, but currently insufficient high-quality evidence to recommend them routinely for CNCP, and concerns about side effects remain.
Given the opioid risks, deprescribing is a crucial skill for GPs. How do we approach that?
It's essential. Needs patient motivation, good support, close monitoring. Withdrawal symptoms are common: temporary pain increase, agitation, insomnia, GI upset, sweating. The rate of reduction needs to be individualized, can take months. A rough guide is maybe 10% reduction per week, slowing down to maybe 5% when below about a third of the original dose. Sometimes adjuvant meds can help manage withdrawal symptoms.
And procedural interventions, like injections or stimulators.
These are definitely in the specialist domain. Should only be considered if realistic goals are set and first-line management has failed. Things like radiofrequency ablation, spinal cord stimulation, certain nerve blocks, always needs expert pain specialist input.
Okay, we need to touch on pain in children specifically. Requires a different approach.
A sensitive, family-centered approach, yes, but the core principles are the same. Active self-management involving the child and family. Key progress measures are often school attendance and playing with peers. Assessment uses careful history, exam, self-report, reliable over age 4, faces scales for younger kids, VAS for older. Medication is definitely second line. Maybe a short trial of paracetamol and SI to help them engage in therapy. Opioids or adjuvants really need specialist input. Evidence for gabapentinoids, TCS, NRIs in kids is lacking, though gabapentin might be the preferred adjuvant if one is trialed under specialist care.
And managing CNCP in the elderly. Big challenges there with medication safety.
Huge challenges: higher rates of chronic pain, more comorbidities, much higher risk of medication side effects and interactions. Principles are the same, but with extreme caution regarding meds. Start low, go slow is the mantra, maybe 25–50% of the usual starting dose. Titrate very slowly. Reassess need constantly. Deprescribe promptly if ineffective or causing harm. Avoid polypharmacy wherever possible.
Finally, complex regional pain syndrome, CRPS. Particularly tough one.
It is. That disproportionate pain after an injury, often in a limb, upper limb more in adults, lower in kids, can follow fracture, minor injury, or no clear trigger. You see those vasomotor changes, swelling, sweating changes, motor issues, trophic changes. First-line treatment is rehabilitation physio, OT focused on restoring function. Early referral to allied health or a pain service is key if self-management isn't working. And there's some evidence that vitamin C after wrist fracture might reduce the risk slightly.
The chapter wraps up with some great practice tips for GPs. Can you summarize those?
Sure. Key things are: build that therapeutic alliance, validate the patient's distress, educate them about chronic pain as a disease, potentially involving central sensitization, use regular appointments for support, prioritize non-pharmacological therapies, set broad functional goals using that biopsychosocial lens, be extremely cautious with opioids, and avoid set-and-forget prescribing, review, and deprescribe. And it mentions good resources too, like the Hunter Integrated Pain Service, HIPS, and pain health websites. Very useful.
Okay, great. Let's try and pull this all together. We've covered a lot in this deep dive into chronic pain. We've looked at the complex definitions, really stressed that holistic biopsychosocial view, and talked about the changing place of medication. And the really key message for practice, it seems, is that this shift towards non-pharmacological strategies and active self-management, well, it's not just a trend, is it? It's increasingly the evidence-based standard.
Absolutely. That's the direction of travel, based on the evidence of what works best long-term with the least harm.
And understanding those different pain mechanisms, nociceptive, neuropathic, nociplastic, that seems fundamental to how you assess and plan treatment. Remembering the risk factors for pain becoming chronic can also help guide those early conversations with patients.
Definitely. Early identification and intervention can potentially make a difference.
So for you, our listeners, the dedicated GPs, what does this mean day to day? It means really comprehensive assessment, going beyond just the pain score. It means open communication, setting realistic expectations with patients, and proactively encouraging and supporting self-management. Medications might have a place, short-term or for specific types, but long-term success really seems to lie in empowering patients with the tools and knowledge to manage their own condition.
That's it. Empowering the patient to regain control and function.
Hopefully this deep dive has given you a useful framework, some practical details to enhance how you manage chronic pain. And as always, exploring the resources mentioned, continuing to learn in this area is going to benefit both you and your patients. So here's a final thought to maybe mull over. Given how huge the impact of psychological and social factors is on chronic pain, how can you, in your practice, find ways to weave the assessment and management of these aspects even more effectively into your standard consultations? How can we make that care even more personalized and effective? Thank you for joining us on Beyond Stethoscope. Until our next deep dive, keep striving for excellence in your practice.